So when the patient develops lung injury, whether it leads immediately to ILD, but ultimately we know for many of these patients it will lead to ILD, the causative agent will need to be immediately discontinued. This is not a dose-related toxicity, and therefore a dose adjustment doesn't mitigate the toxicity. In fact, if you continue with a drug on this agent, the patient will ultimately end up in lung failure and will die. So whenever you see evidence of lung injury, that agent stops completely. It's interesting though. There's one element with the immune therapy agents where we can see pneumonitis that gets reversed with steroids, and where patients can be rechallenged, if it's mild, rechallenged um, at lower dose. And this is a completely different type of pneumonitis, which is not direct lung injury, but more related to an autoimmune phenomenon. So it's very important to think about this, because that does somewhat complicate matters. Uh, an autoimmune pneumonitis can be relatively controlled, but this, what I call idiopathic, because we don't know, frankly, the origin too well, idiopathic lung injury is something that is irreversible, and the agent should not be continued, and those adjustments will not mitigate the issue. Um, Even if the patient gets completely stabilized, or actually this reverses, you cannot restart the agent. Once you have that insult and you document the insult and the injury to the lungs, that agent will never be an option for this patient anymore, unfortunately. Now, then the next question that comes about is, all right, this I can't go with this agent anymore. Can I say go to drug X? Let's say I have a patient who, went through FOLFIRI with colorectal cancer and had a lung injury and ultimately stabilized and went back to a grade 1 or even resolved completely. Am I at high risk if now this is a HER2 positive patient and I want to use this agent, the antibody drug conjugate? Uh, the answer is you probably could, but you have to be cautious. We really don't know if this will predispose the patient for a higher risk of interstitial lung disease that would be caused by trastuzumab deruxtecan. Personally, I would be very, very concerned, especially that the cytotoxic agent itself may overlap with irinotecan. And so for that patient, personally, I would not use the antibody drug conjugate. Let's say on the other hand, it was an agent, we've used gemcitabine or a tyrosine kinase inhibitor, and the patient essentially had ILD linked to one or the other. Can we essentially, and that's a HER2 positive patient, can we go to trastuzumab deruxtecan? And the answer is possibly, with caution. When the other question, would be, what if the patient actually stabilizes but does not improve? And so you have let's say, grade 1 or grade 2 lung disease related as a toxicity related to the previous agent. Again, in this patient, unless I frankly don't have any other options, and the patient seems to be quite stable, and understanding the risk from toxicities, maybe. Personally, I'd be extremely reluctant if there is some level of injury from other agents already as it is to proceed with this agent. So overall, I think, if I want to sum it up in just a brief conclusion, if there is evidence of ILD that's caused by the agent, then the agent needs to be discontinued. With no dose adjustments will mitigate the risk, because that's not a dose-related toxicity. and you won't be able to restart the agent if the patient stabilizes. If another agent caused ILD, like irinotecan specifically, and even if the patient improves to grade 1 or to no symptoms, I would not use trastuzumab deruxtecan. On the other hand, if it's a PD-1 inhibitor that caused pneumonitis that's immune-related, then it ultimately resolved with the proper measures, or you could technically reuse the agent. But for that patient, since there's no evidence of ILD per se, one can make the case, again, if it's HER2 positive disease, to use trastuzumab deruxtecan. And then maybe other scenarios, where you have to use your common judgment. At the end of the day, one has to keep in mind that this interstitial lung disease can be quite devastating for these patients. These patients actually can die from this complication. We've seen it already in a number of studies. I've unfortunately, unfortunately, I haven't seen it in my clinic, maybe because we have intervened a little bit earlier, but the studies have reported it, and therefore that can be quite devastating for patients and their families, and therefore, you have to really use your best judgment when exposing those patients to these agents.